heard about PCR biosystems?
There's quite a buzz about us.
Hop on over to our website to find out more.
Hello and welcome to this Pint of Science 2021 event. My name is Francis Kambili-Mzembe. I'm a PhD student from the University of Hull and I will be your host for the next hour. For this event, we have two speakers who are colleagues of mine. And with that said, please allow me to inform you of our schedule for the next hour. First, we will have Edward Hart, a PhD student from the University of Hull, and he will give us his presentation in which he will be talking about his research into long-term health conditions in seaside towns. And then we will have Edward Muscutt, a PhD student from the University of York, studying under the Hull York Medical School, and he will give us his presentation in which he will discuss how a neglected disease affects some disadvantaged communities in certain parts of the globe. After that, we'll move on to a Q&A session, and this is where our speakers will answer some of the questions that you might have. So please feel free to post any questions that you might have for our speakers in the comments section. Before we move on, I would also like to inform you that you have an opportunity to win a prize, and I will be giving you more details about that towards the end of the show, so please stay tuned for that. Moving on, I would like to highlight the core theme of this event, which is public health in relation to disadvantaged and low-income communities. As a result, our speakers would discuss a range of topics around socioeconomic factors in relation to health. In that regard, I think that some of the issues that will be highlighted by our speakers are relevant in other areas, besides health. Personally, my PhD research is not health related. It is in fact in computer science. However, some of the issues discussed by our speakers are of interest to me in regard to my research. Therefore, even if your area of research or interest or specialization is not necessarily in health, please do stick around, as there might be something in the upcoming presentations that might be of interest to you regardless. All right, without further ado, please allow me to present our first speaker, Edward Hart, who will be talking to us about long-term health conditions in seaside towns. Edward, the virtual floor is yours.
Thank you, Francis. My name is Edward Hart, and my little talk is called Feeling Kinda Blue, Negotiating Multiple Illnesses in Seaside Towns, an exploration of lived experience of multimorbidity in neglected seaside towns. Now, my apologies, should I freeze? The internet connectivity in this area of Hull can be a bit unpredictable, but fingers crossed. So multiple illness is also referred to as multiple morbidity, people living with two or more long-term health conditions, many of whom have reduced functionality in daily life as a result. So I'll be embarking on a study which will be looking at how neighbourhood socioeconomic factors such as employment, transport infrastructure, housing, reliance on the social security system, and the seasonality of resort life affect the lived experience of people living with multiple illnesses, and also how these factors may contribute towards people developing multimorbidity earlier than might usually be expected. So for this project, I'll be collating the narratives of people of working age living with multiple health conditions in a small seaside town, which has experienced a period of economic decline over several decades. And of course, how the pandemic in the local context has impacted upon people's lives. And this little talk just gives a brief overview of the socio-economic environment in which illness both develops and is experienced. And primarily here, I'm looking at the labour market and the social security system. So just a little bit about multimorbidity. It's increasingly common. It's projected to double by 2030 on current levels. And it's not just a problem for older people. 35% of people living in England with 4 or more long-term health conditions are of working age. And 19% of the UK workforce live and work with 2 or more long-term health conditions. Importantly, we also know that the likelihood of becoming multimorbid in working life is much higher in poorer communities. The onset of multimorbidity in the poorest communities in England is 10 to 15 years earlier than the richest. The Marmot review released last year provides plenty of information about health inequality, and it's well worth a Google. Now, many disadvantaged seaside towns score higher than average for health deprivation, according to the Office for National Statistics, within the top 10 or 20%. And they have neighbourhoods which feature within the highest decile overall for overall deprivation in England. Therefore, living with multiple conditions is a more likely occurrence in many seaside communities that have undergone long-term economic decline in comparison to more prosperous areas. So these are just a few examples of localised social and economic determinants of health and multimorbidity. These determinants of health being societal factors that contribute towards the likelihood of illness. Firstly, but not necessarily most importantly, many towns suffer from poor road and rail links. Poor connectivity can make hospital appointments and commuting to work difficult. Indeed, the loss of the rail links to some of the smaller towns in the 1960s heralded the beginning of a long-term decline in tourism. And also the advent of package holidays and people visiting just for the day rather than staying for a week has contributed towards a decline in local economies. This has taken place over several decades, and the declining fortunes of many towns have reflected the decline in tourism. And with a lack of major industries to fall back on and poor levels of business investments, quality, well-paid work with good career opportunities can be hard to come by. Low-paid work and insecure work can predominate in many seaside towns. Indeed, these towns feature significantly amongst the lowest paid areas in England and have high levels of personal debt and insolvency. There are also higher levels of reliance upon the social security system in many of these towns. So these are just some of the socio-economic factors relating to employment that influences health outcomes, remembering that many people living with multiple illness need to earn a living within a weak labour market whilst already experiencing the disadvantage of the particular health problems. So even though we have tourist decline, tourism is still an important feature of the local economy. The labour market of seaside towns is dependent upon touristic services, hospitality and leisure, and I would argue that a comparative reliance on tourism is in itself a health determinant. Employment in tourism can be double-edged though. It can trap many workers in low-paid, insecure work, especially given the absence of other industries. And these jobs are greatly affected by the seasonality of resort life, and therefore work is more insecure and potentially more open to exploitation. Securing a living in winter can be more challenging, of course, especially when the cost of living is higher due to the cold weather. And the stress of financial insecurity caused by low pay and temporary work over time does have an impact on people's health. Indeed, social epidemiologists have identified that accumulation of stress over time is felt more keenly amongst people with less power in the labour market, people who are dependent on work that is not only relatively low paid, but also insecure. Low paid, insecure work tends to afford a lack of control for employees. And again, epidemiologists have demonstrated how poor levels of control over time can be bad for your health. The stress of income insecurity and low pay, therefore, becomes a health issue. And two good sources of reference is, once again, Michael Marmot's, the Marmot Review, but also Wilkinson and Pickett's Spirit Level, and more recently they've written a further book called The Inner Level, provide plenty of information regarding this, bringing lots of different research together. But of course, you know, the COVID pandemic has magnified existing problems. Low-paid workers are more likely to lose jobs, and tourism has been hammered by the pandemic, with seaside towns having been disproportionately affected. So, given the fragility of work at the seaside, the low pay and insecurity, the actual labour market and the touristic seasonal influence of the seaside town, I would argue, becomes a localised determinant of health. Now, many people of working age living with multiple health conditions need support from the social security system. Disadvantaged seaside towns have significantly higher than average claims. And following a decade of public sector austerity, the public system of reassessment, conditionality and sanctioning has become much harsher. Many people dependent upon benefits have been affected tremendously through a more intensive conditionality regime. And you can read about this in Francis Ryan's book, another very good source of reference, called Crippled. And also Kaylee Garthwaite, this is a great ethnographic account of food banks, provide plenty of information, great references there as well. So all this has resulted in many people wrongly losing support, payments being delayed and people being pushed into debt. Although in recent years, the incidence of sanctioning has declined, and perhaps over the last year, that's partly due to the pandemic. But generally speaking, it's still in place, this intensive conditionality, intensive reassessment system. And this punitive system, arguably driven by the negative portrayal of sickness benefit claimants in the media, with a promulgation of a default assumption that people are trying to cheat the system and are lazy and are not really that sick, leaves many people not only in financial distress, but also feeling stigmatized. And to plug another good book, if you're interested, is Mary O'Hara, The Shame Game. That's a very good book in terms of the stigmatization of people on sickness benefits. And compounding this stigma is the stigma of place. Being labelled as deprived, we hear the phrase dump, another stronger phrase has been used in relation to communities. Seaside towns have by no means been exempt from this. Stigma can become embodied in people. Negative sentiments can affect people's perception of their world and themselves. Oppressive attitudes and felt stigma caused by pernicious social judgments can contribute towards people developing negative internal emotional states. And this potentially can shape behaviour and one's psychology in a way, shape one's psychology in a way that one might not be helpful towards their health. For instance, many people may become overly fatalistic about their health. These emotions and stresses over time can impact upon pre-existing illness or developing illnesses. Intense, prolonged states of felt stigma can cause physiological changes, such as increased cortisol levels, which can adversely affect one's health. Michael Marmot's status syndrome, I'll show you it here. A very good reference for that, explains that in much more detail than I can go into. And these are just some of the local examples of seaside factors affecting health and the experience of multiple illness. So what am I hoping to achieve? Well, I'm hoping to promote the idea that public policy should be informed by people's experiences to develop a more holistic understanding of social and economic and neighbourhood dynamics affecting multiple illnesses. And by looking at specific seaside environments in relation to multiple illness, I hope to add a further missing jigsaw piece to our understanding of health inequalities. And with that, I'll pass you back to Francis.
Thank you very much, Edward Hart, for that really nice presentation. And you've certainly highlighted a number of significant points there. And of particular interest to me is this link between labor and health, specifically labor as a determinant of health. That is certainly a connection that was not immediately obvious to me before you had actually discussed it in your presentation. So thanks again, Edward Hart, for for the really good presentation. And I'd like to remind you, our audience, that if you have any questions for Edward Hart or our next speaker, then please feel free to post them in the comments section, and our speakers will then attempt to answer some of those questions later on in the show. Now, without further ado, please allow me to present our next speaker, Edward Muscutt, who will be talking to us about the impact that what he refers to as a neglected parasitic disease, and how that disease actually affects some disadvantaged communities in certain parts of the globe. Edward, the floor is yours.
Thank you very much, Francis. So yeah, as Francis said, I'm Edward Muscutt. I'm a PhD student at the University of York, and I'm going to be talking about some challenges that we're currently facing in controlling endemic leishmaniasis, which is a parasitic disease that I'm researching for my PhD. So just a bit of background about leishmaniasis itself. So it's, as I said, it's a parasitic disease, and it's caused by infection with these leishmania parasites. As you can see, there's a little drawing of what one looks like there, and they're spread by the infection is spread by bites of infected sandflies, and there's a photo of a sandfly there. So it's very similar in regard to the kind of transmission as is to malaria with mosquitoes. It's a very similar paradigm. And there are different types of leishmania parasites, different species which cause different kind of types of leishmaniasis and different symptoms. I'm just going to show a couple of photos of some of the different types and the different symptoms that you can get. So this is just a bit of a disclaimer about potentially graphic images. They're not too bad, but just a fair warning for that. These are just the four main types of leishmaniasis. So we have mucosal and cutaneous leishmaniasis, which are the most common forms of leishmaniasis. And so with mucosal leishmaniasis, you get these destruction of these mucosal layers. So it affects the nose, as you can see in that photo, and it also can affect kind of around the mouth area as well. And it can cause this disfigurement and scarring as well. And cutaneous leishmaniasis presents much more with these kind of lesions on the skin, and they tend to be on kind of your hands, your arms, and kind of areas where you get bitten by sandflies. So tends to be quite visible areas and kind of accessible areas of the body. And the mucosal and cutaneous leishmaniasis, they're the most common, and they're also kind of the least severe, and they do tend to clear themselves up without treatment. However, as I said before, it does lead to disfigurement and scarring as well. The visceral form is much more serious than the other two, and this is because it spreads. The parasites spread from the skin to quite important immune organs within the body. So the liver and the spleen are two very important organs for the immune system, and the parasites can spread to these and cause quite a lot of damage there, and can cause lead to this like big increase in the size of these organs, which you can see in that photo there. And the visceral form is much more serious, and it's fatal in more than 90% of cases if it's left untreated. And PKDL, so if the visceral form is successfully treated, PKDL is kind of a type of the disease that can present after successful treatment of the visceral form. So this is generally just generally presents with these lesions on skin, kind of similar to the cutaneous form, although the lesions do differ a little bit. So these are the four main types. PKDL again is not as serious as visceral leishmaniasis. However, it can the patients can be like these reservoirs for infection, for spreading the infection, as the parasite that causes the visceral form is the same type of parasite. So because these these symptoms and these lesions are on very visible areas of the body, and they can cause this scarring and this kind of disfigurement. There is this stigma associated with this disfigurement and scarring you get from the symptoms, and this can have quite significant impacts on kind of quality of life and and mental health in general, really. So just to highlight that there is this kind of link between leishmaniasis and mental health, and it's not just kind of restricted to the physical symptoms. So just to talk a little bit about my specific research, I'm not going to dwell too much on this because it does get quite it's kind of quite hardcore immunology, but it has to be mentioned. So leishmaniasis is very much a disease linked to our immune system, and my research is kind of investigating how our immune system reacts to infection. So as part of our immune system, we have these white blood cells called macrophages, and these macrophages are very important for capturing and killing things that shouldn't be there, essentially. So I've got this little diagram of just a bloodstream with some red blood cells and some parasites, and then I've got a macrophage as this little Pac-Man. So under normal circumstances, the macrophage will go along and detect and eat up the things that shouldn't be there. So, for example, the parasites, and then it'll kind of release everything that's left over, and it'll kind of destroy it and remove it from the system. And that's how we are protected from infection, really, or one of the ways we are. However, in the case of leishmania, the parasites themselves have found a way to kind of stop that destruction from happening, so they can be eaten by the macrophage, but then not be killed by the macrophage and live inside the macrophage until they can divide and they can avoid detection by other immune cells as well. So this is kind of the way that the infection takes hold within the body, and it's really important that we look at the interactions between the macrophage and the parasite to try and find ways to combat this and to make the macrophage destroy the parasite, for example. So that's as far as I'm going to go with my specific research. I'm going to focus more on kind of the social context of the disease. So just to talk about the global disease burden of the disease. So it's classed as a neglected tropical disease. One of the reasons for this is because it affects lower and middle income countries. So the countries that are most affected are Brazil, parts of Eastern Africa, and also India. And the communities that are affected most severely tend to be kind of the poorest communities in the world. And there are around 1 million new cases per year, with around 26 to 65,000 deaths per year, and a further 1 billion people at risk of getting this disease worldwide. So there is a huge number of people at risk of getting this disease worldwide. And it has to also be said that because a lot of the cases occur in very rural towns, or very sort of disconnected from the kind of the main cities, it's very difficult to get accurate readings for cases. And due to this and also the instances of symptomless infections, the actual numbers are very much likely to be a lot higher than this. So it is a huge problem, and it's been placed as the second highest parasitic disease burden after malaria as well. So just to talk about some of the current treatments and the issues that are associated with them. So just for a start, we have very few treatments available for leishmaniasis, and each of them differ, and kind of you get differing treatments for depending on which type of the disease you have. And they each have varying side effects that are they kind of range in their severity. So they kind of range from nausea and vomiting all the way up to risk of death from heart failure. So these, so obviously that's quite a risk in terms of getting treatment for the disease, and cost as well. So this also goes in hand with the side effects. The safer treatments tend to be the more expensive ones, and as I've said, because the communities affected are some of the poorest in the world, they don't have the kind of income to be able to pay for these treatments. Again, so availability and storage, the more expensive ones and the safe ones tend to need storage in either a fridge or a freezer, which these communities don't necessarily have access to. So that then requires them to travel to the nearest hospital or treatment centre to be able to get the treatments. Routes of administration and lengthy treatments are also a huge issue as well. So for example, one of the treatments requires you to have quite painful muscular injections over 3 weeks. And so you can imagine that if it's a painful muscular injection that you have to get, you're very likely not to go and get it. And the same with another treatment that's a pill that you take twice a day for about a month, but one of the side effects is nausea and vomiting. So this again impacts the kind of desire for the patient to finish the course. If they feel nauseous and they're vomiting every day, then they're very much more likely not to finish taking the whole course of the treatment. And there are also currently no approved vaccines or other preventative treatment for leishmaniasis as well. So there is a real need for us to develop new treatments and new vaccines that are both safe and effective as well. So just to talk a bit about some of the socioeconomic issues associated with leishmaniasis. So as I said before, it's very much a disease linked to our immune system, but it's also very much a disease linked with poverty as well. And I'm just going to highlight some of the kind of issues associated with poverty that all kind of feed in with each other and lead to this increased transmission and increased burden of leishmaniasis in these lower middle income countries. So clean water, malnutrition, and sanitation are all huge issues. With poverty, I think we all know that really, but just to highlight the fact that all of these cause this weakened immune system, and that can kind of make it much more easy for the parasite to take hold within the body after you get infected. So tackling these is going to be of huge importance as well. Co-infection is one of the things that's also very important. So people with HIV have and leishmaniasis together as a co-infection. There is a huge issue with this, and it's by far the most common co-infection is with HIV, and this is most likely because of the kind of this kind of compromised immune system that you get if you're infected with HIV. And people with HIV are around 2,000 times more likely to get leishmaniasis. So again, linking that back to the weakened immune system, it's very much associated with that. Just to move on, so housing, migration, displacement, and type of work. So all of these lead to increased sandfly exposure, which can therefore lead to higher infection rates. So poor housing, for example, kind of damp mud floors and walls that have kind of cracks in them make very good places for sandflies to breed so very good place for sandflies to breed, and therefore if you have these higher populations of sandflies, then you have more infected sandflies and therefore more cases of infections, and also a type of work as well. So a lot of the people do manual labor, so they're very much exposed quite a lot of the time, especially if they're wearing kind of like short sleeve shirts or shorts. So they've got these kind of the areas of the body where you typically get the lesions tend to be these kind of places where you're very exposed for a lot of the time. So education is also a massive issue, public health education more specifically. So if the affected communities don't really know how the disease spreads, or what they can do to kind of combat it and what they can do to limit its spread within the community themselves, then it's very difficult for them to be able to do anything to help the community. So public health education is going to be incredibly important, and kind of just empowering people to be able to to kind of contribute to that combat of the spread of this disease. And there's also some cultural issues as well. So socioeconomic status and gender inequality. So, for example, in places like India, where you have a caste system, lower castes have a lower socioeconomic status, and they therefore don't have the same kind of access to hospitals and kind of treatments that people of higher castes would have access to. And therefore they are more likely to, or less likely to get treated, and also more likely to be infected in some cases as well. And also people who have leishmaniasis and have these lesions on their skin are signs of being part of a lower social class as well. So this then goes back to the kind of mental health aspect and the stigma associated with it. And this also links in with gender inequality. So in some cultures, women don't have the same opportunities for work as men do. So they don't have kind of the same access to the financial aid that they need to get the treatments. Women who have leishmaniasis and have these skin lesions obviously are stigmatized, and therefore they won't be able to, for example, get married or anything. So there is a real issue there as well. And finally, so high treatment costs, both directly and indirectly. And so by directly, I mean the cost of the treatment themselves, and by indirectly, I mean the cost of, for example, getting the transport to be able to get to the hospital to get the treatment. And these affected communities don't have the financial resources to be able to pay for the treatments in some cases. And the same with prevention measures. So one of the most common prevention measures is mosquito nets. And some are even treated with insecticides to help with controlling the sandfly populations. But again, this is they're quite expensive for the communities that are affected, and so they don't have the kind of disposable income to buy these prevention measures. So all of these factors, in some way or another, link to this weakened immune system, which then leads to leishmaniasis. And it is unfortunately a vicious cycle as well. So, as I said before, with the socioeconomic status, having the disease, you're stigmatized against, and then this can push you further into poverty. And then if you were to get treated, you're more likely to then get the disease again in the future. And it is this vicious cycle where you get pushed deeper and deeper into poverty, and it is very hard to break out of it. So really, it's going to be a balance between prevention and treatment in the combat of this disease. So for treatments, ideally, the gold standard we're looking for is a cheap treatment that's cheap to produce. That is an oral drug that you can just take, that has a short treatment course, so one that you need to take over a week or 10 days or so, that doesn't require any storage, special storage of any kind, and that one that can be, doesn't require storage but can be stored for a long time. And vaccine development and approval is also going to be very important as well. And one of the main issues behind us currently being able to develop these new treatments is the lack of funding as well. So hopefully by bringing awareness to it, we can potentially increase funding as well. And prevention, so as I said before, improving public health education is going to be very important, and it's going to help to empower communities to be able to contribute to the effort of limiting the disease. Vector control measures, so sandflies are the vectors that carry the leishmania parasites. So if we can control the populations of sandflies, then we can control the incidences of disease and the kind of rate of spread. And accessibility is also going to be a big factor as well. So if we can improve accessibility of these rural communities to kind of hospitals that have access to the treatments, then these people are much more likely to go and get the treatments if it's much easier and cheaper for them to be able to travel. And then of course, just tackling the core, some of the other core issues of poverty, such as the clean water, the malnutrition, the sanitation, is all going to help with kind of strengthening the immune system and make it harder for parasites to kind of take hold once they're inside the body as well. So hopefully I've just brought a bit of awareness to this disease and some of the issues that are associated with it, and it's linked to these lower middle income countries and these very, very poverty stricken communities. And with that, I'll hand you back to Francis. Thank you.
Thank you very much, Edward Muscutt, for that nice presentation. You've certainly highlighted good points there, and I think of note to me is this issue of awareness and how that is important to prevention. And that is something that was alluded to in the previous presentation by Edward Hart as well. So yeah, a very notable point there. Thanks again, Edward Muscutt, for that presentation. Now we'll be moving on to our Q&A session, where you have the opportunity to have some of your questions answered by our speakers. So once again, let me remind you that you can post your questions in the comments section. Now, before I welcome back our speakers, I would like to kindly remind you that you will have an opportunity to win a prize courtesy of Pint of Science. So please stay tuned for more details about that. All right. Now moving on. Please welcome back our speakers, Edward Hart and Edward Muscutt, for our Q&A session. Now, to kick off this Q&A session, I have questions of my own for each one of our speakers here. And I'll begin with you, Edward Hart. Edward, briefly, could you tell us what methodology are you using to elicit your information?
Well, it's a qualitative study, Francis. I'm hoping to elicit for the people's lived experiences into their narratives, but I'm doing that by means of an ethnography, and I'll be rooting myself in a community, a seaside community, a small community that's gone through a period of economic depression, and I'll be working alongside a local charity that works with people who have various physical and mental health illnesses, and I'll be doing interviews, sort of standard qualitative interviews, online surveys in the community, qualitative online surveys, and I'll also be doing what's known as an ethnography, which will be a bit like an online ethnography, looking at various sites that reflect the situation in the town and how things relate to illnesses and experiences of illness.
All right. Thank you for that response. And it sounds to me like you're doing quite a fair amount to collect your data.
Yeah, I've got to be quite flexible with the whole COVID pandemic, because you never know what part of your research data collection might be affected or how it might be affected. Just got to keep flexible at the moment.
All right, makes sense. Thank you very much. All right, my next question is directed at you, Edward Muscutt. So Edward, briefly, could you tell us what work is currently being done in combating leishmaniasis?
So there is quite a lot of work being done, and it's a really good work being done at the moment. So obviously there's lots of outreach programs that are helping tackling poverty, but specifically leishmaniasis. The World Health Organization has a global vector control response that aims to kind of strategically reduce these vector-borne diseases. So it's not restricted to leishmaniasis; it includes other vector-borne diseases as well. But they kind of trying to implement like sandfly control measures to kind of reduce populations and help infections by that way. And also with vaccines, we've got there's a couple of vaccines in clinical trials. So hopefully in the not too distant future, we might have some newer preventative treatments for the disease. So yeah.
All right, thank you for that response. And it sounds to me like a lot is being done already to tackle this disease. So hopefully it won't be a neglected disease for too long.
Hopefully.
It sounds like. All right, thank you very much for that for that response. Now we'll take questions from members of our audience here, and yeah. So our first question is from Prof. Whitty. Now, Prof. Whitty asks, annual report 2021 will look at health in seaside towns. So has your research contributed?
Well, not yet, because I'm still doing it. It's live at the moment. I'm still at a fairly early stage. I'm second year of the PhD, but I certainly hope it will, because what I hope to bring to my research is the qualitative aspect. Very often with health research, it tends to be quantitative. And I want to put a bit more flesh on the bones of people's experiences in a particular location. So linking people to place and their experiences and how that affects living with illness. And perhaps by adding a different perspective, because I'll add more of a sociological perspective, maybe we can work with the medical perspective to come up with potentially more solutions in terms of providing services.
All right, thank you very much. So I'd like to just make a slight correction here. That question was actually from Jellyhead 143, and Prof. Whitty was actually the author that they were quoting. So my apologies for that slight mistake. All right, so we're ready for the next question from a member of our audience, and this is coming from Pinky Purple Galaxy. So Pinky Purple Galaxy asks, do you feel positive for the future of immunology, or do you feel things are exponentially getting worse?
I do feel very positive about the future of immunology. It's an incredibly fast-moving field, and the kind of the progress that we're making is pretty incredible in some areas, especially if you start looking at the advances we're making in immunotherapy, and like the idea that we're kind of trying to harness our own immune systems to like fix ourselves rather than taking a drug that will do it for us. And so yeah, I think I do feel very positive about it, and I think the past year and a bit has shown us, especially with regards to the vaccines, it's shown us how quickly we can figure things out and produce a vaccine that would usually take years and years. We've done it in less than a year, and I think it shows that if we can all work together towards the same goal, we can do some pretty incredible things, and immunology is not kind of exempt from that. Yeah.
All right. Okay. Thank you for that response, Edward. Our next question is from Sarah Baxter, and Sarah, this is Sarah asks, do the preventions of malaria help to reduce the spread of leishmaniasis?
Okay, so I'm not 100% sure on this, but there is also has been described co-infection with malaria and leishmaniasis. I don't think the treatments for malaria help for leishmaniasis, because these parasites kind of they work in very kind of specific ways, and they kind of have different effects on cells and on the cells of our body that they're infecting, and so it's kind of hard to make a preventative treatment for more than one. So I hope that answers your question. Yeah.
All right. Okay. Thank you. Thank you for that response. And of course, this next question seems like it's directed at Edward Hart. Now, so this is coming from Tim Gibson. So Tim asks, do you see any differences between the problems in seaside towns and, for example, ex-mining areas like Mansfield?
I think in some ways they're actually quite similar in that you have sort of a redundant purpose, I guess, because obviously my industry went decades ago. The same thing happened with, in respect to seaside towns, the lost tourism, and a lot of the smaller towns don't have any, tend to not have other industries around that. I think some of the difference is perhaps some of these smaller towns, seaside towns on the coast, are more isolated and have quite poor connectivity. That makes things like commuting to work very difficult, and if you're ill as well, that makes things even more difficult. So they tend to be further away from economic hubs, which can cause difficulties within the local labour market and opportunities for people. And one of the things that's important with health long term is opportunities. A lack of opportunities does affect us, affects our outlook on life, and has a psychological effect on us and our well-being. So I think there are quite a lot of similarities. I think with seaside towns, the difference perhaps is that there's a blend of urban and rural difficulties. You have urban problems in terms of housing, HMOs, and the rural aspect is often things like, yes, your isolation from, and seasonality, of course. Seasonality is a big thing with seaside towns. Seasonality of resort life, what remains of the resort life.
All right. Thank you. Thank you for that response. Now we'll move on to the next question from a member of our audience, and this one is coming from Rachel Roberts. And Rachel asks, is there anything that can logistically be done to deal with this? So this question seems like it could apply to either one of you, but I think I'll direct it to Edward Hart.
Oh, thank you. Logistically, I think it's a very long-term thing. I think you've got different things going on. You've got the macro and the local micro level stuff. In terms of macro, in terms of health inequalities, on the big scale, I think investing in early years, investing in education. Education inequality breeds health inequality. And in societies where you have already got a certain level of GDP per head per population, one of the biggest indicators of health inequality is actually income inequality. That's a big thing. On a more micro level, or say more localized level, it's connecting up communities to economic hubs. I've mentioned about poor rail transport, road infrastructure, that sort of thing, so people can get to places where things are going on. And also it improves investment opportunities in those areas, and that stimulates the local economy. It gives people more opportunities. And if you get better paid work, better jobs, that improves people's health outcomes. Low paid work, temporary work, 0-hour contracts, over time, it's not good for people. So lots of different things going on. I could go on quite a long answer. But yes, I think there's things to do at a macro level and a more localized level, and ensuring that people are connected to services as well and have that access to information.
Okay, all right. Thank you for that response. Now we'll move on to the next question from a member of our audience, and this one is coming from Jellyhead 143, and Jellyhead 143 asks, isn't Bill Gates keen on giving money to research or eradicating these types of diseases? So has any foundation helped at all? So I think this one is directed to you, Edward Muscutt.
Yeah, honestly, I don't know if his foundation has contributed to the efforts for leishmaniasis specifically. it's definitely something that I can look into. But yeah, he has donated a lot of his money to kind of the eradication of this type of diseases. So I wouldn't be surprised. But it's something that I'll definitely look into.
All right. Okay. Thank you for that response. Okay, so we'll move on to another question from a member of our audience, and this one is coming from Sarah Baxter. And Sarah Baxter asks, I live near Jaywick, one of Europe's most deprived areas. Are there any plans for you to come south for your research? So I think this one is directed to you, Edward Hart.
I would love to, Sarah. I mean, I am with me doing an ethnography. I'm actually basing myself in one town in the north of England that I can get to, given also the COVID situation and travel, etc., etc. But also to give, I do hope to look at other towns as well, to sort of do comparisons and whatever, and to build up a better context of seaside towns more generally. So my research isn't actually based in Jaywick, but I'd certainly love to visit Jaywick. I am aware of Jaywick. There's lots of small seaside towns that have gone through periods of economic decline, dotted all over the coast. And yeah, Jaywick is certainly a place that I'm aware of. And yes, and perhaps I certainly would like to pay a visit. Yeah.
All right. Okay. Thank you for that response. Okay, now we'll move on to another question from a member of our audience, and this one is coming from Janine Hatta. So Janine asks, you mentioned co-infection with HIV can increase the chance of leishmaniasis. Is this also true for COVID-19? And how has the pandemic affected leishmaniasis control efforts?
Yeah, so is it true for COVID-19? So it's a bit early to tell from the data if infection with COVID-19 increases your risk of getting leishmaniasis. There has been reported, I think, a patient in Ethiopia with a co-infection of COVID-19 and leishmaniasis, but it still remains to be seen whether it's kind of the COVID-19 makes it more likely for you to get leishmaniasis. Although they're obviously both immune-related diseases, so it's a possibility. In terms of how COVID and the pandemic has affected the control efforts, so because of all the lockdowns and stuff, especially now in India, where was getting quite bad. A lot of the control efforts have had to kind of take a stop and take a pause, which is going to have quite a significant impact. It still remains to be seen, like how much of an impact, but it in terms of controlling, for example, sandfly populations and that sort of thing, if you take kind of maintaining that control is almost as important as the control in the first place, because if you lose that, the progress that you've made, then you're basically just taking steps back. And unfortunately, that's looking like that might happen due to the lockdowns and such. So it's still a little bit early to tell, but it unfortunately it looks like the pandemic might have hindered control efforts a bit. Yeah.
All right. Thank you for that response, Edward. Okay, we have time for one last question from a member of our audience, and our final question is coming from Janine Hatta, and Janine asks, why have you chosen seaside towns as a location for your study?
I think basically there's a blend of urban and rural problems in seaside towns. Also in terms of a place for actually locating research in terms of health and multiple illness and how that relates to the local social infrastructure. There's not a great deal that's been done. I mean, it is improving in seaside towns in more recent years, but it's still got a long way to catch up to. So there's quite a lot of scope for doing an ethnography that's based in a small town, seaside town, that blends both aspects of the rural problems of geographic isolation and seasonality with some of the urban problems. So that blend, that hybrid of urban and rural problems is probably the main reason why I'm doing it here. But also, there's not a great deal that's been done specifically about health and illness in seaside towns in a qualitative.
All right. Thank you for that response. And with that, that marks the end of our Q&A session. So thank you, our audience, for the wonderful questions. And also a big thank you to you, our speakers, Edward Hart and Edward Muscutt. Thank you very much. And on behalf of everyone here, I wish you all the best with your research. Thank you once again, and goodbye. All right. So this is where I now tell you how you could win a prize courtesy of Pint of Science. Now, there is a feedback form link in the description, of this event. So that's in the YouTube description. And if you fill in that feedback form, and you will be entered into a prize draw where you could possibly win a prize. So please do consider giving us feedback, as that would be really, really helpful for us. And you can also find out more about upcoming Pint of Science events by visiting the Pint of Science website at www.pintofscience.co.uk, and this is where you'll find a complete schedule of the series of Pint of Science online events that are scheduled for the next couple of days. And with that said, that has also brought us to the end of this event. And once again, a massive thank you to our speakers, Edward Hart and Edward Muscutt. And thank you to you, our audience, for taking the time to attend this event. We really appreciate it. I would also like to thank the individuals working tirelessly behind the scenes, specifically our producer, Charlotte Pinkerton, and our master of comments, Phil Boyang. Thank you very much to the both of you. This event would have not been possible without either one of you. And finally, I would like to thank Pint of Science for putting together this series of events and giving us a platform in which we can use to share some of our work and research with you all. So thank you, Pint of Science. And once again, thank you to everyone, and goodbye.